to people. You're not gonna see the skin be that yellow in someone that has darker complexities. Where's a good place to look on every single patient? You know it's gonna be like this on every single person. It's not actually the eyes. You will see it here, but a lot of times you'll see here before even the eyes. Nope, not the palms of the hand. The mucous membranes of their mouth. Like you can see it in their cheeks and into the roof of their mouth, or even like around their lips. Same thing like cyanosis, right? Some of the color changes. So if you look, you can almost see it on the roof of their mouth. It's like a yellow tinge. Because inside your mouth, everyone has the same color, right? It's not gonna be dark, it's more of that transparent look. So icterus is just another fancy word for jaundice of the eyes or the sclera. And a lot of times you see it in patients that have end-stage liver disease. Here are the nursing diagnoses that could come up on your test. So again, not married to the idea of nursing diagnoses, but it's just a way for you to identify what's the main problem here. Always think of your problem as the most severe or the priority, because there could be multiple that apply. Or if you say, okay, Megan, I learned about cirrhosis, I know everything about it, but what does the question want you to do? Because the question might say, they have cirrhosis, but the biggest problem here is they're bleeding to death, right? That has nothing to do with jaundice at this point. It says nothing in the question about jaundice. It's saying the person's bleeding to death. Now the focus becomes, I need to fix the bleeding issue. I'm not worried about cutting my nails short. It didn't ask anything about that, right? So when it's talking about liver cirrhosis in general, what's the problem they're asking? Now, if I just said liver cirrhosis, yes, you could have 20 nursing diagnoses to go with it. But it's kind of like when you have the person that comes into the ED, they have a massive hypertension or malignant hypertension, and they said, I can't afford my medications. Yes, it's a problem, but what's the priority? The high blood pressure. We will fix that problem with the financial situation later. Same thing with this. If it's saying that bleeding is the problem, listen for it. So acute confusion, that can also be not just a risk if they have their ammonia being high. Ineffective protection, I don't think I've ever seen that nursing diagnosis anywhere besides these PowerPoints. But what that's saying is the person that has immunocompromised state, they're unable to protect themselves from infection. So the people that have the white blood cell count that's low. And then impaired skin integrity, we'll talk about ways to help and prevent. And then imbalanced nutrition, less than body requirements. This is specific to people that have alcoholism and they're not having that well-balanced nutrition. So what do we need to do for people that have excessive fluid volume? We need to weigh them daily to look at trends. So typically if you have excessive weight coming on, you will see the trends every single day. So the same thing applies for people that have heart failure. How many pounds do we start to be concerned about per day versus per week? 2 pounds a day, 5 pounds a week. Because typically people can fluctuate. Now if it was one day they had 2 pounds and then the next 5 days they were fine, probably not getting to get too excited. But if it's 2 pounds and then 2 pounds and then 2 pounds, we have a problem here. And that usually is fluid, not fat. And then abdominal girth. You will want to know how to measure this. So you measure at the largest part of the stomach. Most people have a pretty well round stomach, but what if somebody measured at a smaller aspect and someone measured at a larger aspect? It may not completely be accurate. Hopefully you get a nurse that works 3 in a row and they measure the exact same way every day in an ideal world, so you know it's done correctly. Would it be the only way to identify increased ascites? No. There are other ways if that was done incorrectly. We'll look at labs, look at how they're tolerating it. If someone's abdominal girth is so large that it's causing issues with their breathing, you might potentially have people that have to be on oxygen or intubated if it's something where they cannot get a breath and they're very shortness of breath. What do you suspect their urine-specific gravity would be? High or low? High, right? Because they're not going to make as much urine as being retained. Low sodium diets are more so because of the fluid content. I know they typically have lower sodium in nature. However, that sodium is going to be more related to the fluid that we don't want. And they probably have other comorbidities too. And then fluids. How do we restrict fluids? What's like the general rule of how they do that? Yep, they look at the day before's urine output, if they're still making urine, and go by that, and they add a certain amount. Okay, so let's put this in perspective. You have a patient on the medical floor, you know they have cirrhosis, you just looked at their labs and the ammonia is 160. I know you don't know what normal is, but this is high, very high. Okay, so you haven't met your patient yet. Don't gonna do today to prevent a really bad problem from occurring? Of course, death is always on the list, but let's think more realistic. If the person has a complication today with this ammonia being high, what's gonna happen to this person? They're probably, if they have a cognitive impairment, they could make decisions that are not appropriate or what we would think is appropriate in the hospital. So, very first one is fall risk, right? They could potentially fall, which could hit their head, and now their platelets are low. Yikes, we have a bleeding problem, right? So, fall absolutely has to be addressed, okay? How do we prevent falls? This is on your kidney test too. Bed in low position, side rails up, frequent checks, avoid spills and stuff on the floor. I always have call light within reach because what will they want to do? Get up to go get their call light. So make sure they have the necessary thing within reach so they're not grabbing. And then if the person does fall, I'm not saying if you want them to fall, but if the bed is low, you have a better chance of not having injury if they fall from a smaller bed. Okay, that's one thing. What about the trays coming, diet trays? So somebody that has high ammonia levels, we're gonna make sure the dietary knows low protein, right? The person has high ammonia, we do not want excessive protein. So does it mean no protein? No, it just means limit. So maybe one meal has it and the next meal doesn't. Or every meal has a very small amount. So they have some protein, but not a lot. Okay, we could do some assessments with the patient, making sure that they are not getting medications that are making them more confused. So if the person is on morphine, for example, which is not a great option for this person, but if they're getting opioids, that's gonna contribute to more cognitive dysfunction, and it's gonna make them more at risk for falls. I'm not saying any patient in the world doesn't get opioids with liver failure. However, if it can be avoided to give something else, we should do that to make sure they're not getting more confused. Okay? This person is not going to have every 4-hour checks. It's going to be at least every hour, if not more often. These people typically with this high ammonia levels are not going to be on the medical floor. They're going to be in the ICU. And it's more for supervision, or they might have like a sitter, like what are they called, COs, where they have to constantly observe the patient. Okay, so what medications would you expect for this person? Lactulose, and what was the other one? Neomycin. Okay, those two medications will be given. How do we know they're working? It's not just stools, right? Because stools, they can have diarrhea for any reason. It's going to be cognition. If their cognition's getting better and ammonia levels are dropping, that's great. We know that's going to be working. Would we give these medications if they had like an ileus or bowel obstruction? Okay, because if their bowels aren't working, how are we going to get rid of this ammonia level, right? So it's not going to do its job. Okay, and then making sure that they're alert and oriented ×3, or that's a goal. That'd be a very good goal for these patients. Okay, so how am I going to minimize bleeding? Remember when I was talking about the razor thing? I had to go look at it when I was after Monday's class. So it's just razor blade. I couldn't get that from my mind. I don't know why I was having a stroke or something. But electric razor versus razor blades. Blade. What is preferred here? Electric, right? I don't know of anyone that's really cut themselves deeply on an electric razor where it goes bzzz like that. And people that have blades are at more chances of having bleeding, which these people don't have the capacity to clot if they have issues. What are other things we have for bleeding precautions? This will be part of your test where it's kind of a list of things that you want your patient to be on for bleeding precautions. So electric razor, that's one. If they're a man, I should say. Some females could shave their face, but men probably. What about toothbrush? There's soft bristle and hard bristles. They should be on a soft bristle, because if they're on soft bristles, it potentially doesn't make them bleed in their gums. Bleeding gums is always an ominous sign for people that have bleeding issues, because those vessels in there are very heavily connected to the rest of your body. It's like seeing the bleeding from the outside. So bleeding gums, bleeding in the stool are very significant things to assess for. We do not want those things. One other thing for bleeding precautions. Let's think about med administration.
Limit injections.
Of course, don't give them blood thinners, right? We're going to prevent blood thinners. Now, it's kind of going to be dependent on the patient's status, their history, and all the above, but if we can avoid medications that make them bleed, like aspirin, ibuprofen, warfarin, anticoagulants, of course we're going to prevent those things. What other things for med? Maybe the route is what I'm looking for. So oral's the best, right? No one's gonna bleed to death with an oral pill unless it's an anticoagulant, but we wanna minimize the pokes. So these people that they're not gonna have Lovenox and heparin injections because they are bleeding risk, but also just like flu vaccines, or let's say they get a opioid who don't wanna do an IM injection, because that's another poke into their skin causing potential bleeding. They might even get to the point where they get bruised with a blood pressure cuff. Like on their arm, that's how like heavily they are going to bleed. So we wanna do cares as minimally as we can, but getting the job done. Like we're not gonna obviously avoid doing our job, but do things not excessively when it comes to, if you have an IV, let's hope it's a good one. Sometimes they might even just do like a PICC line, because what if their IV keeps going bad and we have to put like 10 pokes, right? These are not the ones that a student would practice on, because they could bleed to death by having too many pokes. Same thing with lab, like if lab comes up to get a CMP, what is something in there that they might be getting every 4 hours that we could probably take from their blood sample? So think about if they have diabetes. Blood sugars, right? So I would poke them on the finger, right, every 4 hours with meals. If the lab comes up at 6 in the morning to get lab draw, I can take that blood sample from that person, right, instead of poking them twice. So those are ways to kind of manage some of those bleeding precautions. Okay? What two vital signs would be prevalent if the person is actively bleeding internally? There's two things. Low blood pressure, high heart rate. What are those types of shock indicating? Hypovolemic shock. I swear that's like, it is a basic principle, but students struggle with what is the blood pressure and heart rate gonna do if someone's bleeding? If you go to OB class and the woman's having a postpartum hemorrhage, like this fall, is the person still bleeding? Yes. Your arm gets cut off, you're bleeding. The vitals are the same, right? Doesn't matter if it's a mom bleeding from her uterus or a person that's hand got cut off and they're bleeding from their arm. The blood pressure is gonna be low, the heart is gonna be high. Do not forget that for your first sim. Because people just forget, like, oh, I don't know what vitals are doing. It's a mom that's pregnant. Doesn't matter, they're still bleeding. Bleeding is bleeding, okay? So then, these are things that can happen to a person that has more of the varices inside of their esophagus and their rectum. But the person that is vomiting up blood, and I'm not talking like, oh, I think I see a little blood in the vomit. No, like clots, huge amounts of bleeding, it is an emergency. And what has to happen is that blood is oozing from their esophageal varices. What do we do for our arm that's bleeding? Put pressure on it, right? They need someone to go down there and put pressure on this varice so it stops bleeding. So we can insert things in the interim before surgery and put pressure on them, which we'll talk about, or they can go into surgery and they're gonna have to cauterize those areas to stop them from bleeding. Would someone die if they bled out from esophageal varice? Yes, it is a life emergency. So hematoemesis, what about hematochezia? What's that? That's the other end of the spectrum, bleeding from the rectum. How do we test for that? Like, obviously you can probably tell what it looks like, but what if it was questionable? You weren't sure if the person, maybe they're taking iron supplements. That's a good one. These people could be on lifelong iron supplements that makes their stool very black. And then you see black stool and you wonder, is it blood or is it iron? How do we test for it? A stool something, yep, a stool occult. Spell it out, it's hard to say, occult. Basically what they do is they take a sample of your poop, they put it on like a pH strip, is what it looks like, tiny little strip, and then they put it in this little like booklet, and it basically sits there for a minute, and it will say positive or negative for blood. So if it's positive, there might be potentially a bleed higher up into the GI system. I was thinking of something to say and I forgot. Okay, here comes your skin integrity. We probably have mentioned more of these than not. I love this one, apply mittens to your hands, because these people are going crazy sometimes with how itchy their skin is. What is the word used for itchiness? There's this fancy word used for itchiness, kind of like when people have hives or anaphylactic shock. Pruritus, right? It's itchiness of the skin. And it's not just, oh, it itches a little bit. No, they're like, everything itches, right? So they might potentially get put on like an antihistamine because it is so itchy. But is that fixing the problem? Like, what is the problem? It's the bile salts on the skin, or it's that stretching of their abdomen where it kind of pulls and it makes it itchy. So a lot of times we will give them antihistamines, but we also think about the medication I just mentioned. Polystyrene. So how does this medication come prepared? It's powder that you mix, okay? And it's supposed to help rid the bile salts that are on the skin, and it makes them urinate or stool to get rid of it. What else does this drug do? There's two things that it does. You learn what it did in farm for this other reason. It lowers your cholesterol. So, we just learned with liver, do they tend to have higher cholesterol? Yeah, so it does two things for this person. So a lot of times this is prescribed because it's well tolerated, and now it does two things for this person that's struggling. And I just mentioned something to you too. Sometimes cholesterol meds cannot, like statins, you cannot take statins with liver dysfunction. So this is a great option for people that have high cholesterol and liver failure. Give me an example of an antihistamine. See if we can make sure we know what those are. Benadryl, right? Diphenhydramine, polystyrene. See how those are related? Okay. Also Zyrtec, those are kind of some of the ones that are non-sedating, because I just taught you, don't give sedating drugs to people that have high ammonia levels. It's gonna make them more sedated. So maybe Benadryl's an option if they're more coherent, but maybe go further to like Claritin, Zyrtec, those options, they're not sedating. One is kind of the earlier generation, one's the later generation. Okay, we talked about weighing every day. These people are not having steak dinners, one because of protein, but also because of they just don't have the capacity and stamina to actually eat these meals. But notice it says promote protein intake if the ammonia level is not high. So if I have a normal ammonia level, or it doesn't say anything about the ammonia level being high, it's okay to promote some protein. I'm not saying high protein, but promote some protein in your diet. Because what is the protein in your vessels gonna do? It's gonna keep the fluid back into the vascular space. So some protein is good. It's just a matter of if they get too much of it when they're in end stage, it's going to be converted to that urea, which is going to cause issues. Okay, here's the two procedures that we'll kind of talk about. So with paracentesis, what do you think would be maybe number 1 and number 2 for risk for a person that has end stage liver cirrhosis? So you're putting a large needle into someone's belly. Infection's number 1, right? So it is a sterile procedure that must be done with someone that's certified to do so. So infection's there. And then also bleeding. Someone that you're puncturing a big needle into someone's stomach that has low platelets, low hemoglobin hematocrit, low vitamin K, you have to worry about bleeding. I need to pull up a picture. Okay, so one of the treatments for esophageal varices, which I'm going to turn the light off here so you can see it. If the person has active bleeding, so people that maybe they have an esophageal varice at the end of their esophagus that's just kind of starting to leak, and they want to put pressure on it, but they don't want to do surgery quite yet. Because think about taking a cirrhotic patient to surgery. Think of all the risks. There's just a lot of risk for a patient that has these issues. So they put this tube inside of their esophagus, kind of like an NG tube. It's the same concept, except for an NG tube at the end of the tube does not have these balloons. So if you look here, an NG tube would go down, and then you just have like your catheter at the end to give meds or give food, whatever that may be. The esophageal varice tube, you're going to have 2 different balloons that inflate. This balloon down here is kind of like the balloon that goes into your bladder when you put a Foley catheter in. It just holds it in place. That's all it's really doing. This balloon has a more important function, and it's to push those esophageal varices, to put pressure on it to make them stop bleeding. Okay? So one of the things that we do during this person is we usually sedate them and we put them on a ventilator. Okay? And the reason why is because A, they're sick enough, and 2, if this migrates up, it can cause a lot of issues with breathing. Because what if the nurse, if you look at these tubes here, what if they deflated this little guy here, okay, and then, or excuse me, deflated this one, and it started to kind of migrate up where your lungs are at. We have to make sure this doesn't move. So if this And we do not want this going further up because it could put pressure on your lungs. So we typically put this in when the person has signs of varicosities of that area. Test question. NCLEX will ask you about these tubes. What should be at the bedside in case the balloon migrates up? So it's a matter of what kind of things do you do first here. So if you look at these tubes that come out of here, one is like the part that puts the pressure, or like kind of like the inflation of the balloon. This one is to, if you put a syringe on there, you push it in there and it's going to inflate that gastric balloon. And then you have one where you can actually pull gastric contents out of the stomach, okay? On your test, I'm not gonna have a hot spot labeling these. I'm just kind of explaining what these little tubes do. But if they migrate up and the patient's starting to have respiratory compromise, they want you to cut the tube. Because what is the tube gonna do if you cut it? Right here, what if you cut this? What if you have the scissors? It's gonna deflate these balloons. And it's gonna, and they're gonna pull it out. Because they want you to breathe. What's priority? Airway, then breathing, and then what comes third? Circulation. This is circulation, airways first. So when it comes to breathing, you have to be able to breathe in order to bleed. So they say if the person's tube starts to migrate up, they'll start having respiratory issues like hypoxia, tachypnea, and if that happens and they identify it's stuck in there, they have to cut the tube. So they always say have a scissors at the side of the bed for these tubes. Hopefully that never happens to you. Okay, so that is one option that's on, I kind of jumped ahead a little bit, but that's one option for the tube. They also sometimes can put down an NG tube, and what they do is they have to carefully go down the esophagus, but that tube can kind of put a little pressure on the actual varices. It's the same concept, it's just one has the balloons, one doesn't. So when they put these tubes down, if there's blood accumulating in the stomach because they're bleeding, what is it gonna do? It's gonna suck out the blood. Because the more blood you keep inside of your stomach and you digest it, it's very harmful to your intestine to have a lot of blood. It just is it makes more stress on your body, can make the person septic and have infection. So they suck that blood out from the NG tube whenever they have the NG inside of there. And then surgery is end result. That's if nothing's working with tubes, nothing's working with, stopping it naturally. So they go to surgery and they can cauterize it, or they can kind of band it off. Because these varicosities, think about on your legs, if you've seen people with varicose veins, and the ones that are really big and bulging, they kind of tie them off so then they can't bleed, essentially. And that's called the banding. Sclerosis is they inject something to make it hard, and it makes them not have any blood flow to that area anymore. So they typically do that by surgery if the person's vomiting large amounts of blood. One time I had a patient, and just every time I say this PowerPoint, I think about him. But he was an alcoholic in his 30s, and he had come in many times with GI bleeds because alcoholism will cause GI bleeds. But there was one day it was his third time in a month that he'd come in, and he was vomiting like tennis ball sized clots, and I was scared because they were literally coming out, and he would not stop vomiting. He would do I remember a whole liter of blood. It's a lot of blood to lose. And it was not vomit, it was straight blood. So his esophageal varices were open, and his blood pressure just kept going lower and lower, like he was gonna crash at 30 years old. And I'm like, I'm not having a 30-year-old death today. That's way too young. So I called the surgeon at 5 in the morning, and they don't come in till 6. And he's like, can it wait till 6? And I'm like, I sat there, I'm like, I don't think so. And he could sense I didn't know. And then 15 minutes later, he vomited again. I called the surgeon, I'm like, nope, you have to come in now. I'm sorry, but he needs surgery right now. And then he came to me after surgery and goes, if you would have not said yes, he would have died today. So that kind of shook me a little bit. So if you have intuition that they should come in, call. It's better to be yelled at to have it done.
The lady in Park said she wasn't puking up blood clots like that, but she was pooping them out. Or they're not, she wasn't pooping, is it her?
For a GI bleed.
Or vaginal, yeah, they're
Vagina or rectum?
Vagina.
Did she have
huge
hemorrhage of some sort, a postpartum hemorrhage or something?
No, she had liver disease, but I don't know what, yeah.
She probably just was bleeding from obviously if it was vaginal, it's probably more of just anything in her body was starting to bleed. I had one like that with a Jehovah's Witness, and she would turn over and poop, and it would be clots this big coming out of her rectum, and I'm like, her hemoglobin was 3. It was 3 or 4. and they wouldn't touch her. She was like 80 years old. She was not a surgical candidate. She would have died in surgery. So sadly, they'd rather have die in the med-surg floor than die in the OR. So yeah, she did die, which was, I was like, just get the blood products, just get them.
Yeah, I think that lady ended up
Just
getting them.
But religious, like you have to respect their decision. I never said one word, like you have to respect their decision. You educate them and say this, you will die if you don't get this blood transfusion. However, that's your choice. And she was cognitively with it. She had her mind, and so we respected her decision. But it's kind of hard. You have to put your own beliefs aside and say it's what the patient wants. Okay, this is that tube I was talking about, but you'll hear it said on the test is a balloon tamponade, is what it basically is. That's the device. Now, everyone on the floor would not call it a balloon tamponade. They call it a Blakemore, is what they'll call it. So if you said to the nurse, hey, what's a balloon tamponade? She'd go, or he'd go, I don't know. If they say Blakemore tube, they go, oh, I know what that is. That's for esophageal varices. So this is kind of where, like, the urinary catheter, no one calls it that. They call it the Foley. Foley's a brand name. So just be careful that in practice, you're not going to hear balloon tamponade. You're going to hear Blakemore. So, if that does happen. Biggest thing is, you're going to cut the tube if you suspect that it is not in the right place. So, do we just cut that sucker whenever we feel like it? No, you have to have something emergently wrong. So typically you're gonna see massive hypoxia and you haven't found out why. You're like, obviously something's wrong here, nothing has changed. So they will take that out. And then most of the time, at the same time that this balloon tamponade is inside the esophagus, they are intubated. A lot of times they're at the same time. And then with this tube inside, it's kind of like having an NG tube. You still want the head of the bed elevated to 45 degrees, just to kind of help with gravity and helping with breathing as well. Okay, so the last thing, I like to show a picture with this because it's hard to explain otherwise, but this is another treatment that can happen if the person has the portal hypertension that's very severe. But they can put this shunt in somebody's liver, and it kind of bypasses that pressure. But basically when that portal vein becomes so inflamed or so big, this is like putting like a stent in there. The same concept of when you have heart surgery and they put stents in to help so the pressure's not so high. This is the same concept. So it just has another vessel essentially, or a shunt. It's an actual artificial device, and it just helps with blood flow so it's not going down the same diseased vein. It kind of produces another pathway for the blood to go. So if somebody has really bad hepatomegaly, splenomegaly, portal hypertension, ascites, this is an option for them to help some of these issues. What would probably be done first before going to a device? The medication, right? Like seeing if the medication will help, the beta blocker, but let's say they're constantly having low blood pressures, heart rates, this might be an option for them if they're not tolerating the medications well. Okay? All right, I'm gonna pull up. We're gonna talk a little bit about CWA. Since we are talking about alcoholism and liver, I would be doing a disservice to you if we didn't talk about the CWA scale. Has anyone got to do this at clinical? Okay, so can you just talk a little bit about maybe what you did? Please, I'm gonna bring you up just because you said it. But just tell me like a little bit about maybe what you did for assessments that you can recall. And that might have been a little bit of time.
Well, I didn't really have to do a whole lot because she had been there for like 4 days now, so she had pretty much gone through withdrawals, but like she was drinking at least 6 beers a day and like smoking a lot, so like it's for alcohol withdrawal, so like you just monitor if she's like puking, if she's got tremors, like.
Yep. So some of the things that you would go through with withdrawal. So you made a good point though. So when somebody is a true alcoholic, I'm not talking like you had 10 beers one night. I'm saying like they have 20 beers every single day. These people, it takes about 2 days for them to get the alcohol out of their system. So most of the time in the first 48 hours, you're not gonna have a CWA scale that measures up to anything because they're not withdrawing yet. You withdraw when your body becomes 0 for blood alcohol levels. Now, majority of the time, day 3 through day 5 are the worst, and then they're okay. So if they were not in the hospital setting, could you die of delirium tremens at home or the withdrawals? Yes. So what do we do from day 3 until day 5? Everybody's different of how long they detox, but if they go from 3 to 5 days, we are giving them something to help with their withdrawals. What do you say? Sid, what'd you say? Okay, she says methadone, so it depends on what your like drug of choice is, if whether it's opioids, something like that, that's a downer too, or you could give like benzodiazepines, because it's a downer, right? They're CNS depressants. So you give CNS depressants because what is alcohol? It's a CNS depressant. So we don't give you a lot, but it's like giving you a little beer every couple hours, is essentially what it is. We're just not giving you a beer. However, I've seen in some hospitals, they will order up 1 beer with every meal, breakfast, lunch, and supper, 3 beers a day. That's nothing to an alcoholic. Alcoholics will have like 20 beers a day. So is the point to get them drunk? No, it's to help with their detox to slowly take that away. It's kind of like when you go cold turkey on a diet. You're like, I want the sugar, I want the fried food, because I'm just having this restriction, right? It's hopefully going to slowly take them off of their alcohol so they're not having an actual cardiac event. So this in itself is the CWAS scale. And I can't even tell you what the CWAS scale stands for, but it's alcohol withdrawal. Can't think what the CI stands for. But these are the categories, and notice, let's just go up to tremors, because we all could probably agree, we kind of knew that with withdrawals. They start to kind of the shakes. But with tremors, if you look at 0 is no tremor, 7 is severe, notice how some of the numbers don't have words next to it. This is a very objective assessment. It is not saying to the patient, tell me what your tremors are usually, what does it look like now, like, right? Like, you don't have this concrete thing that says, they're a 6 and a 5. Yep, I'm pretty sure. It's your personal opinion. So can this vary pretty significantly shift to shift? Yes. However, that's why they do a range. They do a range of like 30 to 38, you're gonna give blank for meds. 23 to 30, you're gonna give this. So you could be off a point or two and it's not gonna really matter, okay? The more things you wanna look for is, they're in the 40s, which is high. The higher the number, the worse they're detoxing. But if you have a 40, and then the next day you have a 20, and the next day you have a 0, what is going on? They're getting better. They're starting to not withdraw as much. But if they have a 0 the first day, 7 the next day, and now they're at a 40 on day 3, what's happening? They're going into their withdrawal stage. So everybody is different. Not every single person will detox the same way. What is normal blood alcohol level in your blood? 0, right? We should have no alcohol in our body. What is the legal limit for driving? 0 is what normal is. We should have nothing. You'll see this on your labs. ETOH. What's ETOH stand for? Go back to Tim's, actually no, be more Bethany's class. It's alcohol. That's what alcohol is. ETOH is chemically equal to alcohol. But we want to be less than 80, okay? So this is blood. I'm talking like you went to the ED when someone's getting a DUI. They take a lab draw, it should be less than 80. This equates to that little machine, the blood alcohol level of 0.08. We've all heard that, right? Like you have to be 0.08 or less to drive. Actually, it's less than 0.08. So once you get to 0.09 and you're driving, what do you get? DUI, right? So what this equates to is 80 in your blood. So this is more like kind of a finger stick that they'll, not finger stick, the blood, or can't talk. The breath, this is the blood. So they're measured a little differently. However, they correlate to each other. So if somebody had a 100, what would their blood alcohol level be? 0.1, okay, and so on. But people that have this, okay, 400 or more, they're out there. This happens a lot. Okay, what would that be for your BAC? They say that this is enough to kill you, or it's enough to, it's 40% of your blood is drinks or alcohol. It should be enough to kill you. However, you'll get the rare occasion that people will be like 0.56. How are they not dead? It's because they're an alcoholic. If this was you and I, hopefully no one's an alcoholic in here, but if this was you and I with a 0.4, we'd be dead. If it's someone that has always, they never get to 0. They might always be, when they wake up in the morning, they're always at like a 0.10 or a 0.18 because they never got sober. They start drinking again. Then the next day they fall asleep, pass out. They wake up, they're already at 0.18 because they were at 0.40. So these people never get to 0. They never have a hangover. This is why alcoholics don't have hangovers. They're never sober, okay? You get a hangover when you're sober. So these people that are over 400 and they're in like the 500s, which is very high, you know they're an alcoholic because they're alive. These people that have 400s should be dead. It's just something where it's when the people are not ever seen. Yep, it was 580, was the highest I ever saw, and they were in the ICU, intubated, because they were not conscious. So that equates to a 0.58. That means almost 60% of their blood was alcohol. It was a Hutterite man, and he loved hoot wine. Have you heard of hoot wine? Okay, me too. It's funny, but not funny, because this poor guy, he did this to himself, but he drank 2 bottles of wine every single night, and he probably had some with breakfast, right? He had it continually, but he came in, he had obviously become unconscious. If he would not have been found, he passed out, he would have died, right? Because of this problem. So when he was intubated, we intubated him for about a day or a day and a half. It was not a respiratory problem, he was drunk. So once he was sober, or more sober, we took him off the ventilator, he breathed fine, and I just remember this because the doctor that I used to work with was not very nice, and they extubated him, he was awake, and the doctor came in and started clapping. Why did he clap? Now this is totally inappropriate, don't do this. He went like this. And the patient and the family were looking at him what the heck's going on? What do you think he said? Congratulations, this is the highest BAC I've ever seen in an alive person. Now how does that rub somebody? A, it was inappropriate. B, is it true? Yes. However, bedside manner, not very good. If you're the highest person a doctor of 40 years has seen, that should say something about the addiction, right? Or probably to the point where this is not okay, I should probably change something in my life. I don't know if he ever quit or not, but that person probably should not have lived. Okay, so other things besides tremors, those are probably the most common, but they don't feel good. Typically during that first couple days, they're gonna get pretty sick. They're not gonna wanna eat, and a lot of times they'll have vomiting too if they are very bad. I'm not talking the immediate, they're drunk and they start vomiting. That is different. When people become intoxicated and their body's defense goes, I need to get this up, I'm not talking about that vomiting. This is 3 days after their last drink, that vomiting. Anxiety and agitation. So anxiety and agitation kind of go together, but they are different. Anxiety means that they literally cannot sit still in the bed, or they're picking at themselves, or they're easily frightened by sounds, right? Or they're just kind of on edge. Agitation means they're mean. Agitation means that they're starting to be short with you, they're kind of yelling at you, they're angry. That is different. The sweats, so they get really flushed faces. If you see a true alcoholic, what does their face look like? It's beet red, okay? We've seen these people where they have beet red faces and they never go away. It's that flushed face. And when they detox, they're even worse. And this is a thing, but alcoholic noses. Have you ever seen a nose from an alcoholic? They're just kind of enlarged, they kind of have that depression in there, and they have a very inflamed face. But when they start to detox, they get super sweaty, their whole bedding is just drenched in sweat, okay? All right, tactile disturbances. They have hallucinations, or they might even see things. This is in the acute stages where if they are starting to hallucinate, they need medication. Because this is not a psychological problem, not like a schizophrenia, this is not related. This is because they're going into that delirium tremens, which is deadly if it's not fixed. Okay, the orientation. If they are detoxing after 3 to 4 days, they start to become incoherent and they don't even know their name sometimes. It is unbelievable how much people can function in society drunk, but once they detox, they are the mentality of a 2-year-old. So sometimes you might see people in the hospital that maybe you know, and you're they have never acted like this, they have no coherent issues, but they're detoxing, and now they're the mentality of a 2-year-old. Okay, I remember one time I had 2 detoxers, I never left the rooms all night, I had to sit on them. I literally sat on them because they would not stay in the bed. So I sat at the side of the bed with my hand on their knee and sat there and charted all night because they would not stay in the bed, no matter what you did. Okay, and we did not want to give too much meds and sedate them to the point where they're unconscious, but at some points you have to kind of realize what is the safety part here that we have to do. That was the worst shift of my life. I can still remember it vividly. And it's hard not to become angry, right? Because you just told them 95 times, stay in the bed, you're gonna get hurt. Because if they fall and hit their head, they could bleed to death, right? Because they have very thin blood when they're alcoholics. So this is your CWAS scale. And then I do just to bring up, actually it goes back, the medications that go with it. So for your test, you'll have to know these medications right here. You've already mentioned a couple of them. Okay. So benzodiazepines, and if you look here, you can kind of see like, we should know what benzos are by this point. So this is not really new information, but just know that we can give it orally or IV. IV is more for severe cases of delirium tremens. But if, let's say they're going on a week or two after and they're still just kind of on edge from not drinking, they might give the oral. If the person actually goes into delirium tremens, this happens a lot in jail, where you will have an alcoholic who's drunk, and they throw them in jail, and they did something actually really bad where they have to stay there a couple days, and what happens? They start to detox in jail. This is not a punishment. They have to come to the healthcare services, or else they will die in jail of delirium tremens. So if they do not get this, they'll have seizures. And if they have a seizure, they could potentially die in prison or jail if they do not get medical help. So sometimes, and I'm not saying all cops, but like sometimes they say, you're drunk, you should go to jail, you're in trouble, right? However, if they are an alcoholic, they should be in the hospital being monitored by healthcare, okay? And then beta blockers, typically we look at more of our alpha blockers as more of the medications they receive. Alpha blockers work more with like the vessels for when they have the high blood pressure from delirium tremens. Because their blood pressures can get like into the 200s very easily when they're withdrawing from alcohol. So none of those are new meds. Beta blockers, benzos, seizure medications. Kind of like knowing how they work and why we give them. Okay, that's all I have.